And in case you get stuck, you call her. She will help you.
Yes. Just 1 second, sir. We'll just start Facebook streaming and then we'll start, sir. Just give me 1 minute.
Done. Sir, it's done.
Okay.
Done, sir.
Shant, can you make me as a co-host?
Yeah.
If I mute myself,
yeah.
Unmute. Yes.
Dr. Sanjeev Upadhyay, co-host.
Yeah. Sir.
What the host?
Sanjeev ko haan mat
Host madbidbega.
Thank you.
Yeah. So good afternoon, everyone. Myself, I'm Dr. Prashant Gowda, Secretary NNF Karnataka chapter. So today is a wonderful day, and all of the speakers have been from morning and spreading the awareness even during difficult times. First of all, from NNF Karnataka chapter, on behalf of NNF Karnataka, we would like to welcome all of you. Dr. Sanjeev, Dr. Sri Krishna, Dr. Soma, Shekar, Dr. Shashi Vani ma'am, who will be joining us soon, and our entire Karnataka fraternity, from entire Karnataka fraternity, we would like to give a warm welcome to you. Thank you for joining. So it's our pleasure to dissipate the knowledge. So without wasting much of time, I would request Sanjeev for the South India to start, have an inaugural speech and mark celebration beginning. Over to you, Dr. Sanjeev.
Thank you, Dr. Prashant and the whole Karnataka NNF team for organizing or celebrating this International KMC Day. So on behalf of UNICEF, I would like to thank all of you for organizing this event in spite of the difficulties which all of us are facing. This situation is unprecedented. All of us are aware of it. We never experienced this situation in our lives, and there's a likelihood we may not face it again. Using a platform like Zoom, what we are doing right now is, it speaks of itself. We never thought in our lives that this is going to be a way to have our conferences in future, and not just one or two. Means we are having such sessions how many times in a day. So this is a new normal for all of us, and I sincerely think that once this COVID time gets over, we will behave very differently. It will take long to get things back, and I'm not sure whether it will come back or it will happen the same way, the way we were doing our businesses earlier. So it's a new normal for all of us. So just few points from UNICEF standpoint of view, and I'll just bring it to this very August gathering. All of us are aware, till few years back, the utilization of kangaroo mother care was hardly in single digits, and this is based on the data what we collect from all SNCUs across the country. And I'm happy to say that with the effort of all of you, all members of National Neonatology Forum and organizations like KMC Foundation and certainly international organizations, UNICEF and WHO, now we are seeing a different trend. Now the utilization is in double digits, though it is still not satisfactory, but at least we moved a lot. With regards to this particular day, I will say that this is a day to bring awareness. This is a day to bring all of us together, national, international, not-for-profit, for-profit, private, public sector, to celebrate, to engage, and to share our experiences on kangaroo mother care. We celebrate the accomplishment of researchers, the staff and families that advance the practice of kangaroo mother care. We engage professionals and parents in learning activities and practicing kangaroo mother care. And we share the amazing stories of people. And we have many of those from different facilities. So we bring those amazing stories of people which touch others' lives. UNICEF and WHO and certainly Government of India, we promote breastfeeding and kangaroo mother care even during the time of COVID. The kangaroo mother care and breastfeeding is one of the key interventions which was less than, as I said earlier, which was less than 10%. But now we are happy to say that it is in double digits today. The COVID scenario has created a sense of insecurity or a fear, and the improvements what we have achieved so far over a decade, now they are at risk. Now this is the responsibility of National Neonatology Forum and all the participants who logged in for today's meeting to see that our efforts don't go in vain. Support from different professional organizations, National Neonatology Forum, Indian Academy of Pediatrics, and similar organizations. So our request to them that they help in restoring confidence in KMC and also reinforce need to continue KMC wherever it is happening. And the last, I thank National Neonatology Forum, Karnataka State Chapter, KMC Foundation to organize this webinar, and hope this webinar, it will restore our faith in KMC and we continue to promote, advocate and support it. So I stop here and wish you good luck for today's session and subsequently our effort towards making KMC a successful intervention. Thank you all.
Very much, sir, for your wonderful enlightenment towards the promotion and the importance of having a teamwork. Thank you very much. So now I request Dr. Sri Krishna, who is a consultant for UNICEF Telangana, to start the session. Followed by that, Dr. Shekar will start, and then in the end, we will have Dr. Shashi ma'am. And then after the completion of all the three sessions, then we will go ahead with the discussion. For today's session, we have got participants from majority of them are doctors and even nursing staffs have joined. So they do have a lot of doubts and queries regarding the projects which are upcoming projects. So I request Dr. Sri Krishna to start the first presentation. So before that, I would request our President, Dr. Kotreshi sir, to speak a few words. Dr. Kotreshi sir. Yeah.
On this day, very important because it is celebrated International Kangaroo Mother Care. I would like to very happy that we have been involving Dr. Shekar, Dr. Vani, and Dr. Sri Krishna from UNICEF. Our main aim is to take care of the preterm babies and small heart babies, which is going to be worth giving prevention of hypothermia, prevention of infection, and breastfeeding activity, and social bonding, which increase the hormone level in the mother. The low-cost level of kangaroo care given a wonderful job. I expect UNICEF to propagate this matter to even at the periphery, even the rural area. All the colleges, all the NSU branches should have a separate unit of kangaroo care. Then only we can celebrate. This is the best modality of prevention of newborn mortality also. So that growth will be more and everything. I would like to happy to know all these servers have joined today. Thank you very much. Nice to go. So over to Prashant.
Yeah, Dr. Kishore sir, who's the Vice President of NNF Karnataka chapter. So a few words quickly, sir.
Good evening, everyone. At the outset, I would like to thank all of you for having accepted the invitation of NNF Karnataka. And today is a glorious day, as our president said, because it's the International Kangaroo Mothers Care Day. And we have a lot of nurses from a lot of hospitals dialing in today. So they're all looking forward to this session. And without wasting much time, we hand over to the speakers, and hopefully this will help reducing our infant mortality rate in a big way. Thank you.
So I request Dr. Ranjan Pejawar sir, who is the President-elect NNF India, to speak a few words. Ranjan sir.
Can you hear me,
Yes sir,
Prashant?
yes sir, yes sir, yes.
I mean, it's a great thought by the state Karnataka chapter to have a web session on kangaroo mother care on Kangaroo Mother Care Day. We all know it is the most cost-effective intervention to improve newborn outcomes. And just today we had a very, very heartening display of dedication as far as kangaroo mother care is concerned from our largest government hospital led by the neonatologist Dr. Sahana. I think we should continue in this spirit and utilize all the benefits of kangaroo mother care and pass it on to our mothers and newborn babies. Thank you.
Yeah, we have Dr. Sahana. I just put the photo of her practicing in our unit. Dr. Sahana.
Yeah. Can you hear, Prashant?
Yeah.
Can you hear?
Yeah, we can hear. Please share your experience quickly and
Yeah, and today is a wonderful day. We had a KMC, International KMC Day, though despite we are doing COVID and non-COVID work, this has motivated me. KMC is my passion. So we did a small awareness for all our KMC mothers. We have a dedicated 30-bedded KMC ward. So we had to call them then counseling, because counseling takes a long way to go. So we counseled them, because to continue KMC even at home is an important thing. So we did the awareness program to all the mothers. Thank you, Prashant.
Thank you. Dr. Dinakar sir, just quick few words, sir.
Start, dear.
Okay,
Everybody is waiting.
fine.
Start, dear.
Over to you, Dr. Sri Krishna. Thank you.
At the outset, good evening, and thank you, NNF Karnataka, for the opportunity to share a few words with you. I would say, overwhelmed by the status of kangaroo mother care as we speak now in 2020 from what it was when I joined UNICEF more than 8 years back. And all credit to the, I would say, the warriors and also the leaders of KMC who have implemented it on field so far. Now we're faced with a situation where we have a pandemic amidst us, and the talk for the next 15 minutes is why kangaroo mother care during and despite COVID. I hope to be able to convince you all why this is very important, and hopefully this will bring about a big change in the way we practice newborn care. Prashant, you can see my screen?
Yes, sir, we can.
Yeah, let me not take you back to why KMC too much. I would like to tell you why KMC now. So, but a few things for us to recollect as we start to understand why. This is one of the biggest evidence we have, the Cochrane review in 2016, and very few interventions have had this much of evidence. And it is very clear, quality of evidence, and the conclusions have been that it's an effective, safe modality of treatment. And let me say, it is a mechanism of treatment. It's like your oxygen, it's like your antibiotics, it's like the warmer. It's a treatment. It is not just putting the baby to chest. And let us start looking at it as a life-saving intervention. How important is it? The Lancet looked at what are all the interventions which can save newborns. This ranks top in priority. Of the postnatal interventions, you see breastfeeding and kangaroo mother care in healthcare facilities as the top interventions amongst the list of low cost, low technology interventions which can prevent the maximum neonatal deaths. Sometimes we forget the fact that of the interventions in the postnatal period, this is the one which occupies 50% of the pie diagram. So if I had to, let's say, pick one intervention, this would be it. This is the one which can save maximum number of newborns, and there's no denying the evidence, no denying the need for it. Now let me quickly take you through why KMC during COVID. The first reason, it is still one of the best interventions to reduce newborn deaths. Before COVID, after COVID, or during COVID, what has not changed is the newborn survival. The same risks continue, the same prematurity, probably a little more sepsis, the same birth asphyxia. The same management protocols, everything stays the same, it's just increased risk. And still the evidence stays the same that kangaroo mother care is much, much needed. We now know that the benefits from KMC and breastfeeding immensely outweigh the risk. There's no question of even comparing it. We have just seen the pie diagram where even if you put all the interventions other than KMC together, KMC alone is the heavyweight in it. Third point, if you separate the mother and the baby, for whatever is your assumption, it adversely impacts not just the baby, but even the mother. You would not be able to breastfeed for 6 exclusive months if you start separating the babies. It is very important that out of the 3 components of kangaroo mother care, the first one is zero separation, and we need to ensure that there is zero separation of the mother and baby. What do you do if you do separate? The baby will end up on formula feeds. What is the risk of introducing formula feed now? It is going to increase mortality, more pneumonias, more diarrheas, more mortality, more morbidity. It is not going to solve the problem of COVID. Separating the mother and baby will not make it disappear, and we are not going to be in a better situation just because you separate the mother and baby. There is no replacement for KMC. Nothing that can deny this particular right of the mother. And until you find an effective replacement, which can be effective in 50% of the cases in the postnatal period, kangaroo mother care should be a right for the baby and the mother. And we have seen evidence so far. Whatever little evidence we have, we all know is only 3-4 months old. 2019 December is when all this started. And whatever we have evidence is very small in number to even make a comment or suggest recommendations. We're still in the process of learning, but we have understood that nowhere have we seen anybody say stop breastfeeding or stop kangaroo mother care. So that's why do KMC during COVID. What is the recommendation across all organizations? This is the WHO's recommendation, the latest one which we could pick up. And you have very clear questions from WHO and crisp to the point answers. The question, in communities where COVID is prevalent, let's say like us now in Karnataka, should mothers breastfeed? And let me emphatically say yes, a big yes, because in all socioeconomic settings, breastfeeding improves survival. It provides lifelong health and advantage to the newborns in terms of growth and also development. It also benefits the mother. The transmission of COVID through breast milk has not been detected across countries, and there is no reason whatsoever to stop or to avoid breastfeeding. The harm that you do is much, much more, and it affects not just this year, but for decades to come. If you stop breastfeeding now and then promote formula, just out of the fear or apprehension that probably you're making somebody go through the COVID scenario. The answer is no. Trust the resource, trust the evidence, and trust whatever learning has come through at that little experience which we have. We can continue breastfeeding even if COVID is prevalent. Now, what if the mother is suspected or confirmed to be positive? Do we still have ifs on buts? No. The answer is yes, you continue to breastfeed even if the mother is positive. Why? The reason is that the transmission through breast milk has not been detected for the virus. And while breastfeeding, if the mother can follow appropriate hygiene measures, I'm sure we'll be able to stop any kind of spread from the mother's respiratory tract to the infant. And if you really give this choice to the mother, no mother will say, I don't want to breastfeed. They will wash their hands 100 or 1,000 times if needed, but will be ready to breastfeed. So mothers and families can be advised that amongst the few cases of confirmed COVID infection also. Most of them have got just a mild or asymptomatic illness. This point we know it in and out. And in contrast, there is a high quality evidence that shows breastfeeding continues to reduce neonatal, infant and child mortality. And we know for sure that kangaroo mother care is one of the best interventions to promote breastfeeding as well. There's been very specific question on KMC as well. So following delivery, should a baby still be placed skin to skin and breastfed, even if the mother is confirmed or suspected to have COVID? Again, a big yes. Immediate and continued skin to skin care, including kangaroo mother care, improves the temperature control of newborns, has better survival amongst newborn babies. So please place the baby close to the mother soon after birth. The numerous benefits of skin to skin contact and breastfeeding substantially outweigh the potential risk of transmission and the illness. You are probably doing much more harm by separating the mother and the child soon after birth, and also denying this right of kangaroo mother care. This is what WHO has told us. What has our own government told us? This is Government of India's recommendation from their Twitter account, wherein they've shared these infographics. And Government of India very clearly states, start to breastfeed the child within 1 hour of birth and exclusively breastfeed for 6 months. Why? As I said earlier, it protects newborns from getting sick, protects them through their infancy and childhood as well. And it is very effective as an anti-infective vaccine. Breastfeeding is the first vaccine that you could give. And there are specific tasks, I would say, and responsibilities for the health facility staff. The infant should, I would say, must be fed according to the standard IYCF guidelines. Make sure you take the necessary hygiene precautions and enable it. Breastfeeding counseling, the psychosocial support, and the support while feeding all make a big difference. The mother and infant should remain together. They should practice skin-to-skin contact straight after birth to establish breastfeeding. Do not promote breast milk substitutes. There is no way a feeding bottle or a teat or anything else can replace a mother or even breast milk. That can never happen. Continue to promote breastfeeding. The benefit outweighs the risk, which is again a perceived risk. If you're taking all the precautions, you know for sure that even the mother would do it, you would do it, then you're passing on the benefit of breastfeeding and not harming the child. This is what Government of India has said. What has been the experience from other countries? Again, over the past few months, experience from Africa has been that very clearly they have indicated that COVID-19 does not spread through breastfeeding. Please encourage mothers to breastfeed. What about Europe? Europe has very clear instructions from the WHO's country of regional office for Europe, wherein their position paper says that the virus has not been detected in breast milk, and they continue to advocate for breastfeeding as well as kangaroo mother care. There are numerous advisories issued by the governments of the countries in Europe and also WHO and also UNICEF. Every advisory has advised for breastfeeding. Please continue breastfeeding. Please continue KMC. The benefits cannot be outweighed by the risk. Last slide. What has Telangana done? I think it is time for all of us to take this very, very seriously. We're doing much more harm, firstly, in not knowing enough. Secondly, in not practicing what we know. Now that we know across all countries, from WHO till our own Government of India, everybody has asked us to go ahead with breastfeeding, continue the most effective, low-cost intervention to save newborns, that is kangaroo mother care. And I'm proud to say Telangana has gone one step ahead, and this is something I would request Dr. Prashant and also the NNF team at Karnataka to do. This is a joint advocacy statement released by the Indian Academy of Pediatrics as well as the National Neonatology Forum, Telangana State, supported by KMC Foundation of India, saying that we endorse, support, and advocate breastfeeding and kangaroo mother care during COVID and also despite COVID. So that's all from my end, and I'm sure Dr. Shashi promised to share much more thoughts on how to do it and what to do. Request all of us to please continue to promote breastfeeding and kangaroo mother care. This is what is saving newborns before COVID, after COVID, and also during COVID. That's all from my end. This is one of the KMC wards in SNCU in Telangana. COVID has come, probably affecting many of us, but work has not stopped and saving lives has not stopped. And kangaroo mother care continues to be one of the main modalities of intervention for saving newborn lives. That's all from my end. Thank you.
Thank you, Dr. Sri Krishna. And definitely on behalf of NNF Karnataka, our president also has requested that we would want to closely work with you and spread the information of kangaroo mother care across India, which we are doing, but with association it will make more stronger and better. So I request Dr. Somshekar sir to start his topic and start sharing. And Shashi Vani ma'am, warm
Yes.
Karnataka chapter ma'am.
Thank you.
I know it has been a very tiring day for you. Thank you. Over to you, Somshekar sir.
Okay, we'll be talking about a little bit about kangaroo mother care and the brain and how it affects the baby's brain. In fact, actually, it's not only does it affect the baby's brain in biological ways, it affects the mothers and the fathers and probably the society's brain in various ways. Okay, so going on to the next slide. So this is a picture that you probably have seen of mothers giving KMC. You can see a buffalo in the third picture. So basically what we want to say is that KMC can be given in all settings. It's not necessary that we need to give it only in the NICU or at the home. It's possible to give in rural settings, urban settings. There are multiple ways, multiple places where we can give KMC. So we need not restrict KMC to a particular geographical area. Okay, so KMC consists of early, prolonged, continuous skin-to-skin contact between the mother and baby with exclusive breastfeeding wherever possible. And these are important components with early discharge, adequate support, follow-up and support. And very importantly, and what is often disregarded or not followed up, is initiation of practice in the facility and continuation at home. It began in 1978, this process by Martinez and Ray in Bogota. Bogota is generally famous for two things, drugs and football. And I think KMC is going to make it more famous, and the world is going to be thankful to Colombia for initiating this practice first. Now, the reason why they began kangaroo mother care is basically to reduce the burden of smaller babies, and because many of the babies were getting abandoned, left by the mothers and fathers in the NICU or in the postnatal ward, and they used to go home. That was the reason why this practice was initiated. So what they found, the number of abandoned babies dropped significantly. Not only that, they found to their surprise a lot of babies who were smaller and not surviving. A large number of them started surviving following skin-to-skin care and KMC in that institute. Subsequent to that, a France national who married into a Colombian family, Nathalie Charbak, began doing a lot of randomized controlled trials in Colombia. And why is that significant to today's topic? Because all the patients that are there in the studies which show brain improvement come from those RCTs. So the RCTs that were done, randomized controlled trials that were done in Colombia, are responsible for the knowledge that we have of the effects of KMC on the brain. I will share a small video. I hope it runs.
As the millions of years passed, Australia began to
one of my favorite videos.
The rainforests retreated and were replaced by grassy plains. As the landscape changed, so did the marsupial mammals.
So you can see the kangaroo which is jumping.
They thrive.
And we'll show you a kangaroo which is going to deliver.
And they're still abundant today.
Kangaroos are basically marsupial animals who are pregnant all the time.
Instead of laying eggs, they produce young without protective shells. And this grey kangaroo is about to do so.
So you can see the kangaroo delivering.
Comes not a shelled egg, but a tiny, underdeveloped little worm.
Tiny, underdeveloped baby kangaroo. It's about 10 to 15 grams in weight and 6 to 7 centimeters long. An adult kangaroo weighs 250 kgs, and this is just about 15-20 grams. A lump of sugar, if you want. It does not have any hind legs, and with its 4 legs, it starts climbing up slowly Okay, you can see it climbing up slowly. And you can see the skin like a preterm baby. It's thin. You can see the vessels, etc. So it's going up to the pouch. From below, it's going up to the pouch.
To survive, it must get to a pouch higher up on its mother's belly. Instinctively, this tiny living particle climbs upwards against the pull of gravity and towards the smell of the pouch.
It goes towards the smell of the pouch. In the pouch, there are 4 nipples where it will start breastfeeding. So the baby goes inside and it can start feeding immediately.
Its tiny mouth on its mother's nipple and takes its first meal of milk.
So this is not the umbilical cord. The baby is feeding right away.
Change to ensure that the infant gets exactly the nutrients it needs for each stage of its development.
And it starts growing inside. No NICU care, no IV lines, no parental nutrition.
It's time to enter
Okay.
the outside world. It's almost
And the baby comes out. This is one of my favorite videos. I never forget to show this, whatever be the topic.
He's a little unsteady at first, but mum offers a helping hand.
Now it's called a Joey.
Known as a Joey. It's all a bit much for one day, and he heads back to the safety and security of mother's pouch. It will be another year before he's fully independent.
Okay, so almost 2 years. So these are the, in short, these are the various benefits of KMC which are there. Breastfeeding, it improves breast milk production, increases the duration of breastfeeding, improves hormone control, decreases hypothermia. You can discharge early, maybe a week or maybe 10 days earlier, or maybe 12 days earlier if you give enough KMC. Definitely decreases mortality, reduces neonatal pain, improves maternal attachment, decreases maternal depression, can be used in neonatal transport, decreases apnea, decreases infections, and also leads to better neurodevelopment. So neonatal pain, maternal attachment, reduced maternal depression, and better neurodevelopment we'll see in detail in the next slides, because all of this connect to a better brain. Okay, so this is a systematic review that that I'm sharing, published in 2016. Prior to this, there were at least 5 systematic reviews published. It's only in 2011 or 2012 where Cochrane realized the data showed that kangaroo mother care helps improve mortality. So this one conclusively showed that mortality is reduced by 30 to 40%, nosocomial infections by 65%, severe infections by 50%, and hypothermia by 72%. It does improve weight, length, and head circumference of the baby, and of course, exclusive breastfeeding to about 3 months. And evidence for mortality effect or decreased mortality in those babies who received continuous KMC, and KMC was started within 10 days of birth. So this is what the data shows, and this probably everyone knows. So this is just to set the stage. Now we'll go to actually what we are going to be talking about is KMC and cognition. How does KMC affect the brain? It is postulated to improve brain function, and there is quite a bit of data showing that it is improving. It affects a lot of things that we think it may not affect. For example, there's a paper published in Journal of Pediatrics, early press, in the press right now, from Australia by Dr. Arvind Sehgal, which shows that it improves middle cerebral artery, brain blood flow. It improves hemodynamics of the heart. There are various things which we don't think on. All these are things which we do in an NICU care environment, and KMC affects all of that. Okay. So how are the ways in which KMC affects this? What are the various possible mechanisms that this affect? Okay. So one is KMC affects sleep, touch, smell, stress, and pain. Okay. So that is it improves breast milk production and effects, and we know breast milk production has an effect on the brain. It changes parental mood, activity, and depression. And it has been seen that those mothers who are having postnatal depression, which actually begins 2 to 3 weeks after the baby is born, most of the time, not all the time, but most of the times. That doesn't have an effect on the way they care for the newborns and the infant, and that affects what is called as executive function later on in life. Okay, so all of these things, sleep, touch, smell, stress, and pain, have an effect on the formation of neural connections. As we know, 1 billion neural connections are formed every second in the newborn brain, and every chance that the neural connections are formed well allows for a formation of a better brain. Decreased disordered sensations such as pain or increased stress for the newborn will lead to poor neuronal connections and decreased sensitivity. There's enough data from animals where they looked at animals which have been given pain, and when they did a postmortem, slides of the brain tissue, they found that neuronal connections were disordered in those rats or in those pigs who had been exposed to pain. So you just imagine that if the same thing happens in us. Kangaroo mother care does modify all of these parameters, and thus what is known is it affects neuronal plasticity. It changes the neurons. Breast milk production, we all know, it increases the breast milk production, duration, and establishment. And we all know that good breastfeeding practices have a direct association with IQ scores. Okay, so this is very well known. So in an indirect way, because KMC improves breast milk production, KMC will have an effect on the brain. Parental mood, activity, and maternal depression. You can even have paternal depression, but maternal depression is more important. Because the parents feel that they are involved in the care of the babies, it is seen that the mood improves and they feel better. They can take care of the baby even better, and they are able to make sure that the baby is not exposed to harmful practices. The neuronal formation depends also on the interaction of the baby. So even though the baby may not be talking back to you, may not be showing any signs of involvement, even if it is a 28-weeker or 29-weeker baby, the more that you stimulate the baby, loving talk or singing or movement, it does result in better neural development. And this thing goes on till infancy and probably throughout childhood. But the best advantage is when it is in the neonatal period, because that is the time when most of the connections are actually being formed. Okay. KMC directly results in improvement in sleep organization, also in brain maturation and brain complexity. So we'll see how it affects each of these. Okay, sleep organization. We know that quiet sleep has its various stages. Stage 1 where it is drowsy, stage 2 there is light or onset of slow wave sleep, and stage 3 where there is deep slow sleep, and stage 4 where there is deep slow wave sleep. So we have this various stages of sleep. It's crucial for creation of a long-term memories and learning. We know that when we sleep properly, we can remember things quite clearly, other than when we have not slept properly. So it affects the baby also. Now, in an NICU environment, a newborn baby, when it lies in a warmer or an incubator, it actually cannot even get 20 to 30 seconds of continuous sleep. Imagine a baby which requires sleep for brain development, not even a minute of sleep properly. Okay, the REM sleep has rapid eyelid movement and muscle movements and increased heart rate and respiratory rate. These are all critical components associated with the development of sensory systems. Okay, so these cycles, sleep and sleep cycles, are essential for sensory development of the fetus and the young infant, creation of long-term memory and learning, and preservation of brain plasticity. It is well known that sleep deprivation of the fetus and neonate has profound effects on early sensory development and creation of permanent neural circuits for the primary sensory system. It is an active process. It is driven by cholinergic cells which stimulate sleep actively, and each specific EEG wave that occurs during REM sleep plays a specific role in sensory system development. So for smell, taste, visual, auditory, touch, all of these sensations which are there, including emotional memory, there are specific brain waves that do happen during sleep. Okay, REM sleep deprivation between 30 weeks gestational age and 4 to 5 months, which is what most of the babies that we look after generally are, results in delayed or disordered development of most of these systems. Okay, so it is a significant thing. In the NICU, babies have a very chaotic version of cycling pattern. They hardly have 10 to 20 seconds of quiet sleep. Heart rate and respiratory rate does not change. Disordered sleep again is because of separation from mother and the noisy caregiving environment. Okay, KMC is seen to increase the quantity of quiet sleep. Okay, the sleep pattern becomes non-chaotic. There's normal sleep cycling. In the subsequent slide I'll show, but I'll maybe mention again here. The reason why we say we should give KMC for 1 hour is directly related to the sleep cycle. The sleep cycle of a preterm baby lasts around 50-55 minutes to 1 hour. So when a baby gets a good sleep cycle, it means it lasts for 1 hour. Giving KMC ensures that the baby gets normal sleep cycling, and that is the reason why we need to give minimum 1 hour of KMC. But as madam will tell you, we should say 1.5 hours, because from putting the baby to KMC and getting it off KMC, if you take everything for 1.5 hours, baby, we are assured that baby gets at least 1 hour of KMC. There are less sleep arousals when baby is in KMC, and heart rate and respiratory variation will occur according to sleep cycles when the baby is in KMC. As I said, it requires around 60 minutes, and it starts within 5 minutes of the onset of kangaroo mother care position. Cycling is needed for formation of neuronal synapses and growth, and this I explained even earlier. But so this is the main point why KMC helps neuronal brain growth. Okay, preemies in incubators demonstrate non-cycled sleep patterns throughout hospitalization, and a result of delay in sleep cycling can affect post-discharge sleep for up to 2 years. So babies who are in incubators go home will also have a disturbed sleep pattern when they reach home. Okay, brain maturity by complexity. So one, I talked about sleep organization. Now we're talking about brain maturity by complexity. What they found was preterm infants who received KMC from 32 to 40 weeks. This is Susan Ludington's paper published a long time back. They had a brain maturation in all the measures of complexity. Brain maturation was better compared to preemies who did not receive KMC. And it was even better as compared to full-term infants. So these are studies based on ages done on these babies. Okay, this is again in 2009, where they looked at 16 EEG studies from 8 preterm infants. They found that those babies who received kangaroo care significantly had better EEG complexity on the right hemisphere, along with areas in the left and right parietal regions, when compared to preterm infants who did not receive kangaroo care. Okay, infants who received kangaroo care had a significantly less number of arousals, as I said earlier, rapid eye movements, and indeterminate sleep, along with increased quiet sleep compared to infants who did not receive kangaroo care. So if you can see, there is enough evidence to show via EEG or via monitoring of sleep that KMC effectively improves sleep and improves brain complexity. They found that babies who had KMC had fewer random eye movements, longer sleep cycles, higher percentage of quiet sleep, lower respiratory ratio compared to both non-KC groups, indicating greater respiratory regularity. Okay, the respiratory sinus arrhythmia and sleep. Those babies who received kangaroo care had higher baseline respiratory sinus arrhythmia and also had a more organized sleep-wake cycle. Now, this is interesting. Earlier, I said that the paper went around 2 years. This particular paper, published in 2014 by Feldman, shows that when they did a term age assessment and even a 10-year assessment, baseline respiratory sinus arrhythmia and sleep organization continued to improve, suggesting that kangaroo care has lasting effects for at least 10 years on the function of the autonomic nervous system. So far, I have shared you data which shows that KMC improves sleep organization or improves brain function at 2 years. And this one particular tells you that we have good function at around 10 years. Okay. Coming to mental development. So this is another one which they looked at mental development assessment at 6, 12, and 24 months. Okay. They had what is called as executive functioning. For those who are not aware of executive functioning, it are those functions which are directly dependent, which directly affect adult life. Okay. Things like initiative, things like withholding back, things like sharing, all these are the executive functions which develop in the first 3 to 5 years of life and have a longer lasting effect throughout life. If you want to know more about executive functioning, it would be good to visit the Harvard website on child development. Okay, those babies who received kangaroo care had better executive functioning at 5 years and 10 years. Okay, and this then also continues to suggest that kangaroo care has long-term benefits as with respect to neurodevelopment and cognitive control. These are a few things on pain. KMC, when it is given, is seen that it reduces pain. So whenever pain happens, the neurons are disorganized and connections formed in the neurons are disorganized. So we should not have pain in babies. Babies should be pain-free as far as possible. And when you give KMC, it does reduce pain felt by the baby. Okay, these are at 90 seconds. These are various studies, and I can share the one which we did first in 2010, 2009. This was presented at NNF conference and subsequently published in 2013 in IGP. We found that PIPP score, the premature infant pain profile score, was significantly low in the KMC group, and even giving KMC for a short duration of 15 minutes prior to the procedure and continuing during the heel prick has pain reducing benefits. Okay, and this is for babies who are more than 32 weeks gestation age. Subsequent to this, we have at least more than 10 papers related to kangaroo mother care and pain, where we show that kangaroo mother care reduces neonatal pain. There's a paper on attachment. This is from, I think, Geeta Gatwala in Haryana. She showed that 110 neonates were randomized into KMC group and at that point of time, routine care group, non-KMC group. They had KMC group had a shorter duration of stay compared to the control group, and the total attachment score, what they counted as the maternal attachment, was significantly higher in the KMC group as compared to the control group. Mothers were again significantly more involved in caretaking activities and spend time beyond usual caretaking as compared to the non-KMC group. There's a small paper on postpartum depression which shows that those mothers who gave kangaroo mother care did not develop postpartum depression during the kangaroo stay. There are more papers that are available. This is just one paper which I have shown. There are things which I have looked at. This was published in Infant Behavior and Development in 2003, and they found that KMC infants had a higher IQ than those given traditional care. Going on to, I'll skip these two slides. Again, they basically show that KMC improves IQ, and these are smaller babies. But the more important or the more interesting studies have been published in 2012, and then later on in 2000, I think 16 or 2016, yeah, 2016. Now, this is the cerebral motor function in very premature at birth adolescents. So this is in adolescents, and they looked at something called as a brain stimulation exploration of kangaroo mother care effects. So this is a study done in Canada in adolescents who were given kangaroo mother care in Colombia. So this is a collaboration between Rejan Tessier in Quebec, Canada, and Nathalie Charpak in Colombia. Okay, what they did was they did a transmagnetic stimulation was applied over the primary motor cortex of 39 adolescents. So out of these 39 adolescents, 21 were premature and received KMC after birth. 18 were premature, that is less than 33 weeks, and had no KMC, and nine adolescents were born at term, more than 37 weeks. So we have three groups where they've done this transcranial magnetic stimulation. And what they wanted to find out is what is the functional integrity of motor circuits in each hemisphere, motor planning, as well as callosal function. The transmagnetic stimulation activates the corticospinal cells of the brain when it is applied over the primary. So basically, you apply something over here, and it activates the corticospinal cells of the brain. And this activation, in turn, produces a response, what is referred to as the motor evoked potential in the muscles of the contralateral side. So you activate a particular area in the motor area cortex of the brain, and it activates a muscle on the contralateral side. So, and then based on when the the stimulation is given and when the response is in, there is a time gap. So that basically tells you the time that the neuron takes to transmit the signal from the brain to the muscle. Okay, and this tells you about two things, because it looks at callosal function or interspecific function as well as motor planning. Okay, what they found that all outcomes are similar between kangaroo mother care infants and term adolescents. So there is no difference between those premature babies who are less than 33 weeks gestation and term babies, and these are typical values as in healthy adults. So looking at adolescents, okay, those who were premature and got KMC as compared to term adolescents, term babies who became adolescent, and they had similar values. Okay, KMC adolescents had faster conduction times, okay, and faster interhemispheric transfer time, more frequent inhibited processes with a better control between hemispheres. Enhanced synchronization, conduction times, and connectivity of cerebral motor pathways in the KMC group suggests that kangaroo mother care positively influence the premature brain networks and synaptic efficacy, and this has lasted up to adolescence. And of course, now if it is lasted till adolescence, it's going to last throughout life. Okay, I think one can do a study when they are old at 60 years and find out what happens. Maybe some of us may not be alive till that time, but I'm sure it will show the same effects when they get old. We don't know. Maybe it will reduce Parkinsonism. Maybe it will reduce all this dementia that happens in adults. We never know. Maybe 40 years from now we'll know about it. So this is a graphical representation. So if you look on the left hand side, There's controls, there's KMC, and there's term subjects. If you look at KMC and the term subjects, both are almost similar. Okay, the latency. Actually, KMC is slightly better than the term subjects, but if you look statistically, there will be not much difference. And controls, which are the preterms who have not received KMC, have a longer duration. Okay, and what again they have found that as the duration of KMC increases, the speed of conduction increases. So there is a dose response curve also with related to neuronal functions. The longer or the more amount of KMC that is given, the better the neurons are. So this is based on just conduction times. Okay. Now this was published in 2012 and this is published in 2017, 2016 December, and it came out in 2017 January or February in pediatrics. And Dr. Sri Krishna would remember that we had presented this in the first KMC conference in Hyderabad. Now this is very interesting. All that we saw so far was 2012, all neurons, brain, etc. So actually, in terms of in everyday life, what difference does it make? So this particular study shows looks at it. What they did is there were 716 participants of the original RCT in 1993 to 96, and they were traced. They traced for 49 of them, and results of about 264 participants are being shown. What they found, the effect of KMC on the IQ or the mental age quotient at 1 year and the home environment was same, was similar at 20 years of life. So what it means is what evaluation you do at 1 year of age for those babies who receive KMC would probably be the same when they become adults or adolescents. KMC parents were more protective and nurturing, reduced school absenteeism, there was reduced hyperactivity in the babies, reduced aggressiveness, reduced externalization, and less socio-deviant conduct of young adults. So when I said KMC affects not only the brain of the baby, I also said it affects the brain of the parents. So this is what we see here. The parents become more protective and nurturing, and they start taking more care of the baby. And this is very interesting. Neuroimaging, basically MRI, showed larger volume of the left caudate nucleus in the KMC group. In the previous slides, I showed you the speed of neuronal transmission, but now it says that the size of the brain or particular area of the brain is much more in those babies who got kangaroo mother care. Okay, they had significantly large cerebral volumes of total gray matter, cerebral cortex, and left caudate nucleus than those who did not receive KMC. This is very important because the periventricular location, all of us who are doing neural intensive care know that there is a hemorrhage in the periventricular location, which is one of the most sensitive areas in prematurity because of neuronal migration. So all this particular area, which is very which can get affected, is helped by giving KMC. The volume of the left caudate nucleus. So again here, the volume of the left caudate nucleus was related to something called the fragility index, which I'll show in the next slide. Duration of kangaroo mother care position. So again, you can see a dose response curve. More the duration of KMC, larger is the volume of the left caudate nucleus, and also the result of fine motor skills test. Better the performance, larger the volume. Okay, so you can see a clear-cut dose response curve between fine motor skills test and the duration of kangaroo mother care. This is the fragility index which they have calculated. I will not go into detail, but it basically tells you that if you have if the babies are more fragile and when they get KMC, they are well preserved. Okay, they found that KMC group had slightly less severe abnormal neurologic results than control group. Head circumference at the end of first year showed an association with IQ at the end of 20 years. That it tells you that when we do examination in the NICU, measuring head circumference is often missed by people. Residents saying isme kya hai, but that is not correct. Measuring the head circumference on a daily basis in the NICU, on a weekly basis in the NICU, and at discharge and at regular follow-up will give an indication what will be the mental state of that particular child when the child becomes an adult. Okay, sensorial and motor mobility was comparable between the group at 20 years. Young ex-KMC participants, so those babies who received KMC, even in the poorest families, had less aggressive drive and were less impulsive and hyperactive. They exhibited less antisocial behavior. Remember, this is Colombia. The Colombian adolescents, they are prone to drugs and crime, and so KMC in that way reduces antisocial behavior, and so they become very significant for a country which has issues. Okay, KMC seems to motivate families to become more child-oriented. They take their children to preschool earlier and provide support, as reflected in the lower rate of school dropout. It promotes paternal involvement in neonatal care and not only affects the family structure but also the environment in which the child grows up. And very, very interestingly, KMC is seen when the parent, etc., everyone is giving KMC. Father's involvement in kangaroo mother care changes the young adult's cognitive capacity. This is all data published in pediatrics by Nathalie Chapak and her colleagues. Okay, so in short, affluence is a valuable addition to infant care. It saves babies. It kind of helps the brain. In financial constraints is the precious gift, and in poverty, it may be the only means of survival. Okay, so with that, I will leave that take-home message that KMC definitely saves life. There is no doubt about it. But there is a lot of flow of evidence happening towards better neurodevelopmental outcomes. Okay, so I would leave you with this, and let me see if there is anything else. Anyone has any more questions? Thank you very much for this opportunity, and I'm very happy that a lot of people are able to watch this. And Dr. Dinakar, Dr. Prashant, Dr. Koturesh, Dr. Kishore Kumar, all of you are doing great work at KMC, because I know what happens in the KMC group, as I'm also a member there. And I'm hoping that we can learn more from Vani Madam as we go forward. Over to you, Dr. Prashant. Thank you.
Thank you very much for that wonderful session, sir. I request Vani ma'am to start the presentation. She doesn't require, sir?
Vani Madam actually does not have a presentation. I am going to run the presentation for her.
Okay. You can start the presentation, sir, so that.
Yeah, I will just start in a minute. So maybe Vani Madam can speak for some time before I start the presentation.
Yeah, sure.
First of all, thank you very much for giving us this opportunity, especially on this special day of KMC Awareness Day. And both the speakers who spoke earlier than me, they have been stalwarts technically as well as scientifically, and they have made my path very easy for me. I probably would not have gone in that depth for each topic, but the topic which I wanted to cover, they have given me a very good red carpet, which I can easily walk on. Can we just start? I have just chosen the subject that now many people seem to know a lot about kangaroo mother care. They probably appreciate that it is good, but it's probably a theoretical approach. We see, though kangaroo mother care is high in impact, but low in uptake. With all said and done, with all these lectures, with all these in-depth analysis, but when it comes to ground realities, we find KMC coverage is globally they had reported less than 5%, but even at Indian level, they have barely reporting 25 to 30% in the states where they are doing maximum efforts, and some of the states are yet to take off. So with this background, I would like to submit that unless minimum of 90% coverage is there, with good quality kangaroo mother care, not just loosely saying, yes, I also do kangaroo care, maybe just for 1 hour, 1.5 hours, last 2-3 days. And that situation should change. And we should come out with much better approach. Only then and only then we will feel the impact of kangaroo mother care. Just talking alone is not going to help us. We have to do it, and do it with heart and do it with brain. So that is the main premise with which I would like to start here. And second thing I wanted to say is, most of the times still people are thinking that it is a poor man's incubator and only for preventing hypothermia. Luckily now at least some vision is expanding and people are realizing that we have got many more things to do, and kangaroo mother care is not to be talked in isolation, but it has to be considered as a part of the routine newborn care, whether the baby is healthy, stable, full term or sick babies. For all the babies at all the settings, it has to be considered. So with these two things I would like to say. Please start the slides. Please.
Presentation is started, ma'am.
Huh?
Presentation is started. You can start.
Yeah, please. Yeah. So second slide, please go ahead. I have taken different aspect here, mainly to say now that time has come that we should not talk that kangaroo mother care has to be given only for the stable, low birth weight or preterm babies. Now the scope is expanding, and right from the burning issue which Dr. Sri Krishna has already told you in detail, that in this Kangaroo Mother Care Day, Awareness Day on 15th May, which every year we celebrate. Next slide, please. This year, especially, we are talking in the COVID situation. So I won't go much in detail because the topic has been already told. Please go for the next slides. Please. I'm sorry, this technical thing. Yeah, so especially this year, the emphasis is kangaroo care in the COVID era. Now, origin of kangaroo care, enough have been talked. You may please switch those slides, Dr. Shekar. Please, next slide. Next slide, please. Bogota, they have said. And now the question also has been answered, whether we have to say. But in this stage, I want to put one important disclaimer, that our experience, information, and quality data regarding COVID-19 are limited. So guidelines may have to be changed depending on the emerging different evidence. So we are not saying this is the final guideline or this is the best guideline. Currently, with the available information and available situation, and considering the mother's best thing which we can offer, this appears to be the best advice. And finally, one more thing, we have to allow the mother to take the final decision in COVID situation, whether she wants to practice KMC or not, and whether she wants to feed or not. And we can only counsel and guide her in good faith. Next. So with this disclaimer, already Sri Krishna has said, and just repeating, that breastfeeding is life-saving, benefits are more, risks appear less, and without breast milk, problems are many. And vertical transmission of COVID-19 through breast milk is not known so far. We do not know about tomorrow. Next. Next. And another message also has been given. If you want to practice breast milk, then observe other precautions also. Now, details have been given, so I'm not going. Another important aspect I want to highlight again is risk of mother-infant separation. They outweigh the benefits of babies being together and given KMC, breastfeeding, and other things. This is one practical aspect I would like to put for consideration. The goal for separation is mainly to prevent virus infection to baby. So many people, especially corporate hospitals, are those who consider them that they are working with affluent communities who abide by their advice. The first thing in their anxiety of preventing infection to the baby, they tell that keep the babies separate in case the mother's status is not known or she is already known to have corona positive status. So now, earlier even in USA and other places also they have been following this policy. And so, earlier means only just last few weeks ago, even in the month of last week of March or even early month of April. But soon they realize that hospital isolation may delay the infection, but may not always prevent the infection. And then the next stage of learning is infected newborns mostly are mildly sick and they have less mortality as compared to older age groups. So with these two things, and they found if you separate the baby from the mother, the breastfeeding suffers because of the multimodal thing. Mother is stressed, baby is stressed, many other negative consequences also outweigh the benefits. So decision to make the thing short, decision on separation. Only on individual case-to-case basis you may decide if the mother is seriously ill, critically ill, maybe has some other problems, yes. But otherwise, Do not separate COVID mom from her infant. If you are not able to do any good, but at least you do not do the harm by separating the most loving diet from each other. That is the one message we would like to give. And why we are giving this message? It's not only relevant for the COVID situation. Even pre-COVID era also we found unnecessary mother-baby separation was going on. I have been pleading for this for past quite some years. Just because the baby is delivered cesarean, just because the baby is low birth weight, just because there was meconium strain Laker, just because there were twins, multiple births. And we found any number of situations, or I can even put a little harshly excuses to earliest separate the babies from the mother. Keep the baby under observation in the warmer till the mother becomes fit, or till we decide the baby is fit to go to mother, and so on. So this avoidable, preventable situations of mother-baby separation have to be minimized. So that is another consideration I would like to put here. Next, please. So scope for KMC needs to be expanded. So it is not only for the stable low birth weight babies, even for the sick babies, even those, and the more expertise you have, the more qualified staff you have, you can even improve the scope for taking up the babies, even on CPAP also, for kangaroo mother care, even on mechanical ventilation also. In fact, in many of the countries, this has now become a routine. Taking the babies on mechanical ventilation also on mother's chest, and even other high intensive care units also are doing this. Why? Of course, just to put in a very simplistic way, the bonding increases, stress is much less, the neuroendocrine inputs are much better, and naturally the oxygen need is much less, and several other justifications are there. So that is another thing. Second thing is, routinely also when you give, even for the stable babies or other babies in the hospital, you are not able to keep the babies up to the ideal time which you would like to have, till the baby gains more than 2,500 grams weight, or the baby is able to breastfeed well. And there are so many family constraints, so many other things, and ideal situation may not be there. And cost and other factors are there. So because of all these things, many times the mothers have to leave, and then we have to make sure that at least post-discharge KMC is continued at home. Now this post-discharge continuation of baby KMC at home, currently at least in India, there are three situations. One is the ideal situation where the baby was born with all the antenatal care and good care in the hospital, and then it was identified as low birth weight, preterm baby, and the best of the care was given in the hospital. Parents were ready, staff were ready, everything was available, but still they had to discharge these babies at proper time as per the hospital policy. They go home and they have to continue KMC at home also till the baby decides that no, now I don't want any KMC. We don't go by any particular gestation or birth weight, but baby decides. And even after the baby decides it does not want continued KMC, but sometimes during cold weather or soon after birth or during night time, the baby may like to have intermittent skin-to-skin contact with the mother and some KMC. Another situation which is much more commoner now is institutional deliveries have increased. Low birth weight baby incidence is much higher, but still we find that babies are not able to keep in the hospital for some time, and then they have to go back home and they have to continue KMC at home at least. And the third situation, which is coming less blissfully, but still continues, that deliveries continue to happen at home, and for several reasons, they are not able to avail of facility-based care. And this home-based KMC, especially in resource-restricted areas, more preterm babies, more low birth weight babies, and they need more of KMC, including breastfeeding and other advice. So this is the scope for the continued KMC at home, what we call it as community-based KMC or even home-based KMC. Now, during transport also, KMC has to be improved. So these are all the few immediate scope which we have for expanding the scope for KMC. We will quickly go through what scope we have in tertiary care units. Next, please go for the next slide. So relevance of kangaroo mother care in tertiary care newborn units. Next, many tertiary care units are afraid to even bring the babies there. Of course, now the scenario is gradually, blissfully changing, but still there are units where they do not allow mothers because of the fear of cross-infection and others. They forget that cross-infection is much more when the health workers are handling the baby than when you allow the mothers. Anyway, Kangaroo Mother Care Foundation has always put up these slogans. Mother's chest is the best place for the newborn care. Mother's milk is the best food for the newborn growth, and zero separation of mother and baby. And thankfully, Corona period has given us the big push that we are probably right on our approach, and it may be readily applicable even in this COVID era. And we want to see that it becomes part of routine care for newborns with birth weight less than 2,000, but for all the newborns in all the settings in all the areas. That is even International Bogota Declaration that KMC has to be promoted at all settings. Next. Now, when we made this setting, we are now happy. Please go for the next slide, please. That even from the Scandinavian countries, where there are no lack of any infrastructure, staff, cost, and other considerations are not there, they have also now declared. Dr. U.V. Ewald, one of the very high proponent of kangaroo mother care and coming from Sweden, and he has also been telling us almost the first lecture we heard in 2012, but now even the new place of care for the premature infant is the chest of his or her parents. They are also coming back to that, even for the premature infant. Next. And now the scope is extended not only for the stable premature infant, but even for the sick and unstable infants also. Now an international study is going on, and Delhi Safdarjung Hospital is one of the participants where they are trying to learn the impact of kangaroo mother care right from birth, even in the unstable babies. Soon after the resuscitation is established, and if the babies are critical, even these babies have to be given kangaroo mother care. And they have found that everywhere, wherever kangaroo mother care is being given, the results are coming out very, very satisfactorily. And probably they are now even abandoning further studies because the results are so good. So coming back, rather than leaving our babies for the emotionless experts and the equipment, let us involve the bonding of mother and families also in the care of even critically involved babies, and that is in the tertiary care units. Next. So what is the scope we have and what is the justification? Many of the justifications already be given. I am just quoting a few case histories here from the private practitioners who are practicing it. So here is a baby with 500 grams. Please go for the next one. Here is please go for the next one. 500 gram birth weight. Here is a 27 weeks thing. Here the quadruplets from Baroda Hospital. And all these are getting much more benefits by involving kangaroo mother care even in the tertiary care units. Next, please. There are several examples now, and in India now, we want to recommend them even in the intensive care units. And why it is recommended? First of all, the incidence and severity of infection is much less, longer duration and exclusivity of breastfeeding, increased weight gain, all these have been already told. All that I want to highlight is apnea and bradycardia is much less, crying is much less. Now, just like the sleep science is now giving a lot of benefits, recently there are a lot of papers that crying is also playing a lot of crucial part in the baby's outcome. So less crying is much helpful for the babies being calm and for their physiological stability and probably improving their circulation and neurodevelopment also. Many papers are coming up for allowing the baby cry. Dr. Niels Bergman introduced that concept to me earlier, that soon after birth, we first look up for the sign that babies should have a lusty cry. And we thought crying is a good indication for the well-being of the baby. But nowadays they are saying we need not allow the babies to cry. Yes, in full-term babies, crying is okay, they can adjust. But in preterm babies or low birth weight babies, especially extreme preterm, micro-preemies, in all these cases, crying may sometimes have been having some adverse effects also. So that effect also has been said. A lot of things have been told about sleep and improved state of organization. Next, please. Please go for the next slide. And another important human aspect is, previous slide, please. Just previous. Provision of opportunity for mother and father to establish a critical relation with the infant. And provision of low intensity stimulation to the developing senses. Many of these statements have come up again from the references by Dr. Susan Ludington, Dr. Niels Bergman, and Swedish and Canadian studies. Enhance parent-infant bonding, increase parental confidence levels to handle their low birth weight babies and preterm babies. And it also helps for the babies to regulate their behaviors in feeding and non-nutritive sucking, etc. Next one. Next one, please. And it provides a rest period from the often noxious NICU environment. We have had enough justifications for that in NICU environment, we should have a developmentally supportive care with less noise, less hearing, and circadian rhythm being provided for the babies and all. But kangaroo mother care and baby's chest, baby gets everything which it wants, along with the mother's love and affection. And of course, enough things I've said about the development, so I'm not going further. Next. So we have enough justification to say that cardiopulmonary effects are also not affected much. Resting and things are affected much. And sensations that have helping for the brain development, which already Dr. Shekar has mentioned. I'm just demonstrating. By keeping the baby on mother's chest and allowing to breast, you are having multimodal stimulations right from the beginning, which helps for the synaptogenesis, plasticity of the brain, molding of the brain, and brain development. Next. And the same thing, please go for the next slide. Same thing can be achieved on mother's chest even when the baby is not feeding. Baby gets the familiar heartbeat, reassuring voice, contact and touch, baby feels safe. So body also calms, brain also calms, and by calming the brain, body and brain, naturally you are stimulating many positive influences and which help for the health and development. Next. I'm trying to catch up with the time. And in incubator, when you keep, naturally strange sounds, scary smells, bright light, and baby is put on a avoid pathway, naturally sympathetic stimulation is there, and that requires a lot of metabolism, energy expenditure, and many incidences of hypoglycemia, hypothermia may be related to even this care also. And in kangaroo mother care, we know thermal synchrony is also achieved, and all these are not there. And not only immediate, but in the long-term effects of the baby care, maybe even some of the poor immunity and non-communicable diseases may have some origin for this non-supportive, non-developmentally supportive care of the low birth weight babies. Next. So kangaroo care can address to several barriers for the developmental care in the NICU. There are numerous caregivers, so naturally exposure to infection is also probably more. With all due care also if you give, but that love and affection may not be there, and several other factors are there. Numerous interventions, so no quiet rest period. People generally don't think of the pain management and giving rest to the baby much. That cluster approach which we are recommending, that is also much less. Medical equipment use is also much less. Maybe because of the kangaroo mother care, all these can be lessened a bit more, and prevent movement and self-regulating behavior. And another thing is, very often the schedule of the caregivers is at their convenience and not at the convenience of the baby or mother. When they want to give IV, when they want to give medicine, when they want to encourage breastfeeding, many times it is the caregiver schedule, caregiver's convenience becomes a thing. And I am reporting all these from the reported documented literature. And the sleep-wake cycle is of course chaotic and fragmented. We have had enough of that. Next. So, and it can address many of the developmental barriers also, which also again has been told elsewhere. So I'm not saying, but another important aspect is pain and discomfort from procedures, separation from parents, inappropriate or excessive sensory stimulation, which I told you, unnecessarily if we separate the mother and handle the baby much more naturally, excessive sensory stimulations are also there. Alternate feeding practices without pleasure or enjoyment of the baby. This is another important consideration. Unnecessary formula feed, unnecessary top feeds, unnecessary stimulation, not keeping up with the baby's demand, but we often go by the time schedule. So nowadays another lobby is also coming up. Even in the babies, low birth weight babies also, you decide the feeding schedule according to the demand signs which the babies are making, rather than going only by the time cycle. Then babies are confined without pleasing touch of parents. So that is another justification for introducing parents in the thing, and medications that cause sedation, irritability, and agitation. So these are all other barriers which are there in the NICUs. Next. So with all this justification, please, and zero separation, I have given you enough justification. So all that I want to emphasize is here, mother's body is a biologically normal place for care of the newborn, and better outcome for normal, healthy, as well as smallest preterm newborn when the babies and mothers are together. And that has to be encouraged even in the tertiary care units. So people have to maybe redesign their schedules, policies, and facilities to achieve these things. Many times we say we do not have enough staff, we do not have enough space, but if we feel the need strongly, we will try to create all these facilities. Next. So what are all the situations? So here we are trying to do nesting, we are trying to give warmth, we are trying to minimize light, and trying to give the baby something like a womb-like safe, cozy environment. But the same thing can be easily given by a mother if you involve her. Why not? Next. So toxic stress which is there, which we have already talked, so I want to say, and there are many endocrine and other studies done to justify this state. So in short, keep the babies together, even in the tertiary care units. Next. Please go for the next one, please. So prevent mother-baby separation. Next. And that is why we call kangaroo mother care not as mere skin-to-skin contact, but a loving body hug between mother and its newborn, full of emotions, full of love and affection, along with all the other physical parameters. So potential of KMC to reduce mortality, there are multimodal things which we have already known, so I'm not going again. Next. because we have highlighted these things. But what are the clinical applications? Now coming to that. So think of all possible situations in your NICU, how you can keep your babies and mother together. As I already told you, proper protocols to be designed and good quality training to be staff to be given. Explanation, counseling and motivation for all the staff is much more important, and then come the parents. Then proper counseling of parents and family for their cooperation, compliance and conviction in KMC during even NICU stay. They have several apprehensions. Naturally, you have to help them out to come out of it. And to help them out, first you have to be convinced and you have to be competent enough to advise them, and then only you can practice that. So ensure stress-free newborn and mother with better quality of outcome. Next, please. So I'm just giving you a few common situations where you can do. So the first thing is paradigm shift in the newborn care. Earlier we started KMC because incubators were not available, but now even when they are available, we will say that we will use it only when KMC is not possible. So please give a serious thought to this thing. Next. So common situations where mother and baby separation can be avoided. Next, please. Soon after birth, you have to put the baby on mother's abdomen, especially after the resuscitation thing. Cesarean is one of the commonest excuses for delaying the breastfeeding and delaying mother-baby contact. That also now we are justifying with full evidence that it is safer to give babies earlier, immediate early KMC, even in cesarean cases, provided other things are okay. Scope to minimize separation of mother in NICU. Next. Happy parents giving twins following cesarean. Next. Even in mechanical ventilation. Next. Even in when the babies are receiving oxygen therapy. Next. When the babies are receiving phototherapy. Here they have shown Billy blanket, but even with our available phototherapy units also, we can safely give kangaroo care even under phototherapy units also. Next. Next. Heel prick are such minimal painful interventions, procedures. They can be easily done keeping the baby on mother's chest so that the baby feels painless, recovers fast, and it is easier to handle the baby. Mother is also less anxious. Next, we can think of many number of situations. Next, please. And even screening for ROP, that can also be done in KMC. Many of the Western, not many, quite a few of the Western countries, now this has become a common practice. Even USG is also done by keeping the baby on KMC. And even in our country now, as I said, in Safdarjung Hospital and others, they are now, and we are also requesting for even transport, even within the hospital also, from labor room to mother, or even for the investigation, transport the babies on mother's chest or even on the health worker's chest. Neonatal transport in KMC, that is now an immediately doable thing. And I want to talk about it just one more minute, that even with the best transport incubators and best transport team, people have now reported that transporting the babies on KMC appears to be much better and safer. And they are now, along with the transport team and transport incubator, they are developing a transport team in KMC with training, kit, and other things. South Africa, they have now made it a mandatory legal mandate that every newborn, premature, even sick newborns, even babies requiring surgeries, cardiac surgeries, even if they are transported in helicopters or vehicles, they have to be transported in kangaroo care. If father or family member or mother is not available, even the transport team member is expected to provide kangaroo care, that is skin to skin care. So that is one more thing. Incidentally, I want to clarify one more statement. When we say kangaroo mother care, it doesn't mean only mother has to give that care. Kangaroo care can be given by anyone, but mother is the one who produces breast milk. And kangaroo care gives a lot of emphasis for promoting breast milk feeding even to the low birth weight babies, even to the sick babies, premature babies. And that is why conventionally, whether the care is given by father, mother, grandmother, anybody, but the term is used kangaroo mother care to emphasize the importance it attaches for the breastfeeding. Anyway, that was incidental. So now I was talking about transport incubator, and even in the transport incubator and comparative studies are now available, that they are saying that it is much safer. And in our country, where the incubators are not available, such ideal facilities are not available, mothers are available or some family members may be available. If not, even the emergency medical technicians can also offer this. And we are now working for this. It has to be naturally combined with a lot of motivation, training, supplies, and possible adverse events. If at all they occur, we have to be ready to tackle that. So only if when we are prepared for all that thing, we will go for the transport for the critical care. But when nothing else is available, even today you can advise transport of the low birth weight or preterm babies in kangaroo care within the hospital or from the outside, whether it is short distance or long distance, it has got much more benefits. It not only prevents hypothermia, but it also minimizes infection, mother-baby bonding, and several other advantages which we need not reiterate again. Next. So this is one thing we have talked. And of course, community-based kangaroo mother care, I have mentioned to you earlier, but that also we are now developing it as a separate module, and it has found necessary in India even today. I won't go in much detail here, but at least I will make you aware that that aspect is also now being attended to. Next. So in the communities also, we have shown by some small studies that it is safe, it is feasible, it is acceptable by our women and family members. We were thinking that people may not be taking, or male members may not participate, but all that ideas have gone. And ICMR has shown with a small study also that it is feasible even in urban settings, tribal settings, village settings. And the recent path-breaking study from the Haryana group, Applied Sciences and that group, they have shown that it has a great impact in reducing morbidity and mortality in the community settings also. So there are several now evidences are coming up and needs are arising to promote kangaroo mother care, even in the deprived societies, but even in the middle income or other societies also, we require a lot of awareness generation to propagate kangaroo mother care. In fact, today's day and today's meeting should serve that purpose much more better than what we have been doing earlier. Next. We have found even in the remote areas it is possible to do where nothing is approachable even by transport or trained health workers. We are training village health workers for some minimum skills, and we are getting good results, even in the remote tribal areas, hilly areas. Next. Next, please. So in short, I have told you that kangaroo, yes, so at home also, and we have again and again said it is not just mere skin superficial touch, but it is the tender loving hug, as we call it, mamta ki jhappi, between mother and her baby. And it has got several positive impacts, and kangaroo care provides that opportunity and advantages both to the baby, mother, and even to us. Next. Next. So these are all some of the examples we are quoting. These are the farm laborers near our Anand. Twins were there. They were less than, one was less than 1.4 kg weight, another 1.6. Due to several family and other constraints, they could not go to the hospital, even where everything is available free of charge. So in that case, our health workers stimulated these mothers and both the parents to take up the care of these babies through kangaroo mother care and breastfeeding and other simple measures. Babies are doing very well. Next. This is another good example. Please go for the next one. 600-gram baby delivered in a hospital, but it delivered in the early hours of the day. Because it was reported 600 grams, the doctor thought it may not live much. So he did not even bother to come to see the baby. He advised the birth attendant, who was skilled enough, to say either they can take the baby to higher center or they can take the baby home. Luckily, and being naturally coming from poor families, not aware that everything is available free of cost, or maybe they did not have even means to go to the higher hospital or transport, and other constraints were there. They went back home, and our health worker, she went back, she was motivated. She motivated the family with the mother and her mother-in-law. They reared the baby from almost 12 to 14 hours of kangaroo mother care, alternating with each other. And today this baby is almost 8 to 10 years old, doing very well even in the studies. These are just a few anecdotes. But when I quote these anecdotes, our colleagues sometimes tell me, Madam, are you giving them a wrong impression that hospital care is not required or incubator care is not required? No, I'm just telling them that if nothing is available, even in those situations, kangaroo mother care can help them a lot. But naturally, ideal will be to start with facility-based care and then continue at home-based care. Next. And several such things are coming up now. And of course, Corona things have been told, so I'm not going further. Again, in the end, thank you very much for giving me this opportunity to express my passion about this topic, and ardent request to you all to expand the scope of kangaroo mother care in your sphere of activities. Thank you very much, and I thank the organizers also for giving me this opportunity.
Thank you very much, ma'am. Now the session is open for questions. So anybody who have doubts, I think Harish Chalani, I'm trying to unmute. Let me see. Okay. Yes. Anybody has question can directly raise the hands or post it in the group. We'll be able to put it for discussion. Meanwhile, Dr. Dinakar, sir.
Prashant.
Yes, sir. Any questions from your side, sir, from Facebook and YouTube?
First, let me just thank the people. Dr. Krishna. Hello, Dr. Krishna. Sri Krishna. I think so. He's not listening.
I'm here. Yes, sir.
The way you started was excellent. Number one, you told first vaccination given to the baby by the mother by the breastfeeding. Super word. Excellent. Number one, I think so. It is a thought of the day, or we have to tell everybody that is good. And your talk is good. And we want from you and your boss together from the UNICEF, please join hand with Karnataka NNF chapter. We are always there to take whatever you people need. We are ready to help you. That is number one, Sri Krishna. Number two, Shekar sir, it was very good, really good. Madam ji, as usual, I don't want to tell anything. You are a mother of kangaroo mother care, whatever it is. It is excellent, madam. I think so. Many people have. We did today in our hospital also a good session of KMC, and we called all the mothers. I think so. Today everybody did like Dr. Sahana also. I think so. If anybody is having any questions, please ask. Dr. Prashant, over to you.
Thank you, sir. I think
Dr. Prashant, can I
Yeah,
just make a quick comment.
Please.
It's very important for us to take the momentum from KMC Day forward. Many a time we do this, and I request everybody not to keep it as a day. Ask ourselves, how many of us have written kangaroo mother care in the OP note of a less than 2 kgs baby? Have we really done it? One of the key barriers is our own selves. If you spend 2 minutes telling any mother, please do KMC, share resources, I'm sure the mothers will be happy to do it. Doesn't depend whether you are practicing in the corporate hospital or in a government hospital or even in your clinic. If at the end of the day, starting May 16th, every pediatrician and every NNF Karnataka member can write kangaroo mother care in your prescriptions, talk about kangaroo mother care for every baby who is less than 2 kgs, I think the effort which we all did today will make sense. And we are very, I'm sure UNICEF and also KMC Foundation will be very happy to support. Let's take up surveys, let's take up periodic such assessments. People who would like to do it, we are happy to help. But this has to carry on. The momentum has to build. You can't just have certain set of people do it. And we all have understood the importance. Now it's time for advocacy to move into action. And that is where the real gains are.
Please don't limit only to the low birth weight babies. Only thing you can say is no low birth weight should escape, but every baby should receive this advice.
Yeah, that's much better.
Yeah.
It just is 3 letters and 2 minutes of your time.
No low birth weight should escape, but every baby should receive this advice. That is much better.
So Dinakar sir, 3 minutes of everybody's time and 3 words. Kangaroo mother care for every baby. That's all we ask for. Thank you.
Yes, kangaroo mother care for all babies.
Chalani have questions. Can you unmute them and can they ask the questions? They have raised their hands.
Prashant, unmute everybody. Let them ask questions.
Yeah, I've unmuted Dr. Arish Chalani.
No, unmute everybody.
Yeah. I've done. Please go ahead.
Thank you. And first of all, I congratulate UNICEF, IAP, and especially Dr. Shashi, Vani. Now learning has been there now.
Harish, it's not IAP, it's NNF. Huh? NNF Karnataka, it's not IAP.
Sorry. Yeah. Okay. What I was trying to say that, we have got now great learning, but now we have to move on to the action, and science is there now. We know the advantages, and what Dr. Shashivani mentioned that there is only 5% globally implementation of the KMC. Now the challenge is why we are having this, because we are keeping the mother in the postnatal ward, keeping the baby inside. So if you want the processes to improve, we have to make the infrastructure available. So what I think the UNICEF had done the great job when the SNCUs were launched. They had the good hand holding of the, with the government, and they supported the initial few units. I was involved in the 2006, 2007 when these guidelines were made. But now I think the time has come, and the ministry is also supporting that, as Madam is saying repeatedly. Now, when we say together, means the mother's bed has also to be moving closer to the baby. Now, when the mother and baby, they are together, it is only possible then to have the effective long
I think we lost Dr. Chalani, sir. One second. Yeah.
I think he muted himself by mistake.
Yeah.
Maybe
Hello.
I'll just.
Yes, sir.
Yeah. If you want to improve the processes, I think the infrastructure has to be there, and we need to bring mother and baby diet together. And so there will be, the opportunity for me.
I think the internet, there is an issue. Harish sir, we are unable to hear you. Hello. Yeah. Okay. We'll move to the next question.
There's a question that I want to take.
Yes, sir.
I think this was from Dr. Amit Suel. He has asked the question: what is the minimum duration of KMC, total cumulative hours, which translates into a statistically significant positive effect on neurodevelopment of baby? I'm afraid I don't know the answer, so that's what I can say. But the problem is the question. We should not be looking at minimum amount of KMC. We should look at maximum amount of KMC. So from the question, I would like to suggest that we should not be talking about minimum amount at any point of time. We should be always talking about maximum possible KMC, because that is what we need to do. The reason we don't know the answer is because it involves a lots of variables. Babies who are smaller, 26 weekers, babies who are 32 weekers, what other problems they have, the amount of duration the KMC they receive, how much they receive at home, and so on and so forth. So there are lots of issues that are involved. So to get a minimum amount of KMC would be difficult. But if you are asking what is the minimum amount of KMC that you should do, while we would want to say at least 8 hours, that's what Suman said in earlier webinar, we should at least go by what is happening on an average. So I think a minimum of 4 hours per day. If you're not even meeting 4 hours per day, that means you're not doing anything. If you're reaching 4 hours, I would say, okay, you're at the bottommost level of this, and then you can start climbing. So what is the minimum amount that you should give to say that you are giving some amount of KMC? Maybe 4 or 5 hours in a day. But if you're doing 10, 12 hours in a day, I think it is a good amount. And if you're doing 16 and 18 hours, etc., for every baby, I think it's a large amount.
I think Sugandha has raised the hands. Sugandha, please go ahead.
Yeah, I have just 2-3 practical questions in this COVID era, because I'm from Safdarjung Hospital, and Dr. Shashi Vani was referring to our unit, mother in NICU, where we are keeping babies, low birth weight babies, even in the 6th state. Now, what is happening in the last few weeks in this COVID era? We have separated COVID suspect and confirmed COVID mothers in other building, and COVID non-suspect are delivering in a separate building where we have this MNICU. Now, what we are facing practically, and I want guidance from all the experts, what we are facing problem is that what do we do in the COVID suspect and COVID mothers, confirmed mothers, where babies are in NICU, COVID NICU? How do we call these mothers inside, especially for low birth weight babies? When this situation comes, it's ethical to get this mother in, number one. Similarly, in COVID non-suspect areas also, nurses are very apprehensive now the mothers in for feeding and KMC. How do we handle these two situations in COVID nursery as well as non-COVID nursery for sick babies? If Dr. Shekar or Dr. Shekar, anyone.
Madam.
Please go ahead.
So one of the things that, because we had Dr. Deepa Pankar in an earlier talk where they're looking at COVID babies in the NICU. I think it's mainly to do with counseling. There is enough evidence to say that breast milk, etc., does not have any kind of virus in it. Whatever transmission that may have happened in newborns would probably be more from other people rather than horizontal transmission. And the WHO guidance and the UNICEF guidance is definitely there. We should be giving kangaroo mother care and breast milk to all babies. So I think because the guidance was not very clear initially in March when we started getting these babies, and there was a lot of separation that was happening, people got used to it, and now suddenly with the guidance which has changed, maybe 10 days back, 7 days back, people might find it difficult to move to continuing with KMC, etc. So with the conflicting, with the rapidly changing guidelines, people have a difficulty in changing, especially when they fear about getting infected. I think mothers have to take a... Yeah, madam, yes, go ahead.
Yeah, can I say something in this context?
Yes, ma'am. Especially, ma'am, for nursery babies, I was.
Yeah. So from that angle, I am telling you. Now, just to be very brief, we start with one disclaimer here, right in the beginning, that our currently available experience, information, and quality data is very minimal. But considering many other practical situations and difficulties, WHO, UNICEF, and many other agencies have now come up with the following recommendations. Promotion of breastfeeding, we have already talked. Keeping the babies together. They said our main apprehension of separating them is preventing the infection to the baby or others. So infection of the baby, at the most, you may delay it or postpone it, but probably once they go home or under other situations, it may not be possible. So the babies may get infection. You observe all possible precautions to minimize it, but don't just get bogged up with the probabilities of infection spread, and do not separate the mother and baby. And another thing which they have found out is direct contact transmission to the newborns is known. Very few are getting that, but even those newborns, the disease means the clinical situation is very minimal, not very serious, and they come out very well. So far, no adverse effects are known unless there are some other comorbidities. In newborns, the comorbidities may be mainly in form of congenital defects, some life-threatening congenital defects, or some genetic or immunological problems, and they are not in the form of hypertension, diabetes, which we tell about the older people. So comorbidities and that, but considering the possibility of COVID infection and the things and weighing the other benefits, they have categorically analyzed the situation, and at least as on today, they are recommending that weighing the balance between the benefits and the risks. Even now, we can allow the baby and mother to be together. And they have given several justifications, and I have got at least 18, 19 references and personal experiences from the different countries, including Australia, Canada, China, UK, USA, France, and I can give you those references. So considering all those things, you can formulate your policies under your thing. So main idea of telling you here is breastfeeding can be definitely promoted. Kangaroo mother care is safe, and don't separate the baby and mother only because of the threat of the infection to the baby. This is one situation. Now you were talking about your practical situation. Now we have a situation where many mothers are not, all of us are not tested, and we can be still non-symptomatic and non-tested person harboring the virus. So when the situation is not known, allow them. When corona positivity is known, and if non-symptomatic, allow them. Mildly symptomatic, allow them. And even if the baby is seriously ill, if possible, allow them. But if separation has to be done, only in critical cases, or take up some case-to-case basis. So only on case-to-case basis, you can decide about the separation, but not as a general policy. And this is as far as today is concerned. As Shekar is saying, tomorrow if something new emerges, policy may change. So another request is, all of us are requested to keep quality data, analyze our data, and evolve our strategies, share our information with others, learn from others' experiences, and then make suitable changes in the policies. So policies can, at this time, when our experience is limited, information is limited, quality data is limited, we cannot say, but we cannot delay our policies, what we think good for the baby and mother, just waiting for the strong evidence to come. Even today, babies are being born. Much more, many more babies are expected to be born as they are projecting. So we have to be prepared right from now. And this is not a temporary phase. Probably we have to be ready for a few more months or maybe even years to come. So our plea here is all with your senior people is take steps right from
I think Madam got disconnected.
Yeah, sir. We have one question
Yeah, so
from Dr. Gautam from Texas. Sir, what is the role of kangaroo mother care in end of life care? For example, in a dying baby or one in whom care is being redirected from intensive care to the comfort care only. I have to admit that in the USA we are not very good at KMC and need to improve. Yeah, I mean, sir, yeah, this is the question what he has asked. He has joined us from there. Yeah, please, sir.
Thank you for the question. One, I can tell you that we are not doing it, so we have not done it, and I don't think anyone will try that out as of now. I'm not sure. I have heard that people I don't know if it's published, but in Europe, probably some people do it. This is what I have heard, but not seen a presentation. In our hospital, we have something called as Code Krishna, the link of which I have shared in the chat group. Is available freely on the net. It's published in Indian Journal of Medical Ethics, where we do something just around or after the time of death to address these concerns of dying. But this particular thing about babies who are going to die or are dying, and whether we should offer kangaroo mother care to them, I don't think we will be able to analyze that question, mainly because in most hospitals which are private or where there is some fees to be paid, parents usually take the babies home, and they want the babies to they want to spare the expenses, and they would prefer that the baby goes home and dies at home. So I don't think we will ever get to that in a private setup. In a public setup, I think there is too much burden of care in terms of healthcare resources or healthcare personnel available to be able to do this, and even so in that area possibly we will not be able to do that. But it's actually a very good idea. So we have had babies where babies have died in the NICU after long care. The parents have had done what do you say, religious activities by the side of the warmer, or got some priest to chant some Bhagavad Gita verses, etc. So that has happened and can happen, and we definitely do it for babies or neonates once they die in the NICU. So we do a pretty there's a particular protocol which runs around for 10 or 15 minutes. So that is done for not only newborns or children, but all adults also. So that's a standard protocol which happens all across the hospital, and that's published. So I can just say that.
Yeah.
There's another question Dr. Amit Swell has asked, what is the practical method for multiple pregnancies? So twins and triplets. So I think Madam mentioned in her talk, I think Madam has gone out, alternative KMC providers, kangaroo care providers. So AKPs, so fathers or grandmothers or grandfathers or siblings can do. So you can have 2 or 3 people doing. If you join us for a chat in the evening at 8:15 on the IPA web channel, we'll have parents talking. So we'll have a mother of triplets actually going to be describing how she's going to be doing kangaroo mother care. So I will leave a link to that channel in the chat later. But she will be talking. So she had triplets. Those triplets are now about 10 or 12 years old, 10 or 11, I think 12 years old. And she gave KMC in the US. So Dr. Gautam, this mother delivered triplets in the US, and she gave KMC in the US to all the triplets. So she'll be talking about that experience later at around 8:15 or so. So it's possible to give if the father is large and stout, he could place 2 babies. And I think Madam shared some pictures of twins, quadruplets, where there were 2 people giving KMC to 4 babies. So 2 babies per person. So that kind of thing is possible. Yeah. Thank you.
Dr. Srinath Manikanti has raised hands. Please go ahead.
Fantastic learning today. One new learning I had today is kangaroo mother care can be used for transport in resource limited setting. I want to ask if transport incubator is not available and the baby has only mild distress needing only nasal prong oxygen, can these babies safely be transferred by father giving the KMC, because mother will be there in the peripheral hospital who has just delivered. Then father can give the KMC, and can we transport this baby to the tertiary center?
So I think it's definitely possible. There are no studies. I don't remember any studies being published in India. I think we should do one. But in our unit, long time back, maybe around 7 or 8 years back, we have transported a baby who is 1.4 or 1.5 kg post PDA ligation from our hospital via railway to Indore. In KMC position. So they learned KMC in the hospital. So that is around 400 kilometers or 8 hours of travel. It's possible to transport small babies. We also routinely advise when babies come back. This is followed in, I think, Mumbai, in KM Mumbai for almost last 15 years. So they do KMC transport, or when parents come for follow-up to the KMC follow-up clinic, they come with the baby in KMC position. So it's possible to do this transport quite easily. There's no published data, but I don't think we should wait for publications to do that kind of transport.
I think
it will be very useful for a country like us. Definitely, if more and more people come forward and share their experience, and especially in the resource limited settings, it will be very useful. Thank you.
Yeah, Dr. Srinivas has raised his hand. Please go ahead.
Congratulations to all the team members, NNF team and UNICEF team for organizing this very useful of the KMC annual day. I want to appreciate all the speakers. I have one comment regarding the palliative care. Previously, I wanted to ask a question from USA.
See,
yes,
your voice is not clear. The voice is not very clear.
Okay. Can you hear me now?
Yeah, better. Please tell me.
Yeah. So, shall I repeat? Because you have not heard.
Please repeat the question.
Okay. So first of all, congratulations to the NNF team and the UNICEF team for very useful meeting today.
Thank you. Mm-hmm.
All the speakers have delivered excellent lectures. I congratulate them. I have a comment regarding the palliative care.
Mm-hmm.
Yes, babies who are dying also, parents will hold during that difficult time. It's always discussed with parents in UK practice. If they are willing to, it's encouraged. And also, there are centers like a hospice centers. When there is a palliative care is required, the mother and baby will be transferred there, and they can be looked after together. So this is well practiced in UK.
Okay. Sir, were you able to get the question, sir?
No, he was informing that they do this thing in the US. I don't think he asked a question. I couldn't get a question. Is that correct?
It was a comment only.
Comment. Okay. Because it was not clear for me. Anyways, does anybody have any other questions? Yeah.
Dr. I'll just take a minute.
Yeah. Tell me. Go ahead, Doctor.
For those who will, for those who are more inquisitive to see what China did, well, they initially banned breastfeeding because it's first of its kind. Nobody has any clue what's happening in China. I imagine at that time, at least we have something to look at. So they stopped breastfeeding. Then they realized they had a better option of allowing breastfeeding, doing testing, and probably that's the way out. Find what is the bigger gain and then do it. And a suggestion for those who are trying to implement KMC, see, the best counseling which we have found effective is you tell a mother for the past 10 days, 15 days, no, you have not gone anywhere. The best place for a newborn is inside you, literally. Nobody else touches the newborn. There's no chance of the infection coming to you. We all have read this quote, the infection doesn't fly in the air and come. You have to go touch it and then come back and put it inside your mouth or your nose. So you both stay together. Nothing will happen to you. And trust me, This has tremendously increased KMC. We have found actually 3 kg babies also being put on KMC in government hospital SNCUs, and the mother says, the one beside me is doing it, and I feel that is the safest place for the newborns. So please make best use of this opportunity wherein people are trying to be as stay at home as possible. And in this process, we'll be able to promote KMC. That's all from my end.
Yeah, I think all the questions have been answered. There is one last message. What is the terminology that is used in Hindi or Kannada or other language for kangaroo mother care? Same term, or is there any different term used when explaining to the parents?
It's the same in Telugu at least. I'm sure it's the same elsewhere.
No, we call it kangaroo mother care, but when Vani Madam explains, she usually uses this of a monkey, because monkey is kind of cling to the baby in a similar fashion. Indians have not seen kangaroos, but they've seen enough monkeys. So I think you can just, I can't get the name of the exact Gujarati what. Vandra. So Vandra is a monkey. So we can use that terminology. We call it kangaroo mother care, but while explaining, we can use the example of a monkey. It's much more easier that way.
Okay. All right. I think I request our president. Yes, sir. Yes, sir. Yes, sir.
Sir, after seeing Shekar video for kangaroo care, when the baby has taken care from the mother, I think the kangaroo care should not be changed. It should be go through the same name, because that care taken by the preterm to the 2 years of mother and kangaroo baby is excellent only. And we're very good message to spend in all the languages that should go for a kangaroo care. 1 point. Second thing I want to add is Dr. Vani's presentation is extremely good. The kangaroo care should be started when the baby is stabilized in NICU immediately after day 2, day 3. When discharging the baby also, you should sit with the discuss. The word custom was Banantana in Canada. So the mother and child should not be separated. So should be kept in the same like kangaroo care, so that infection has been controlled very much. Very nice topics was certainly presented by, and I myself thankful for Karnataka area for this. My boys are doing wonderful job. Dr. Dinakar and Dr. Prashant. Though I am in Shimoga, they are doing wonderful job on this. Hats up to them. Thank you once again.
Thank you. Thank you. So before we close, let us all pledge to each other as a responsible neonatologist and practicing pediatrician, holding the responsibility of future of the generation. Oh, you have one question? Yeah, please.
What is the difference between rooming in and KMC method? Second, how long KMC is continued? 2 years, 3 years, or 4 years?
Okay. So the question is, how long can the baby receive kangaroo mother care? So the textbook answer is till the baby tolerates. So what happens is, when the baby is receiving kangaroo mother care for a week, for 2 weeks, for 3 weeks, at some point of time, the baby decides enough is enough and stops remaining in that position. So that's actually the best time. So when does that happen? We really don't know. We don't know what decides of how the baby decided, but generally it is roughly when the baby becomes more than 2.5, 2.6, 2.7 kgs. Now that brings us to the question whether term babies should receive kangaroo mother care. So a lot of people ensure that even term babies get kangaroo mother care. Babies go to sleep faster. Okay, the parents are also calm. And so babies do like remaining in the chest to chest position, skin to skin position for a longer period of time. In that particular position, it could be generally baby would probably have received, if it's a 1 kilo baby would have received KMC for at least 1.5 to 2 months or 3 months. It depends upon the baby and the way in which it gains weight. But I would think roughly around 2.7, 2.8 kg, then baby decides it's enough. It also might depend upon the season and many other things. But there is no well-defined time when we should stop KMC.
Oh.
All right.
What is the difference between rooming in and KMC method?
Yeah, so we did a study long time back, published in 2014 in Journal of Perinatology. What we did is, for all those babies in the postnatal ward, so these are babies who don't get into the NICU, maybe 1.9, 1.2 kg or 2.1 kg, who are low birth weight, often slightly premature or maybe term SGS, who remain in the postnatal ward. And we tried to ensure that all of them got skin to skin care immediately after birth, about half an hour, 45 minutes after birth, when they got roomed in. All of them remained in skin to skin care for as much as possible. So we were able to get on average 16 to 17 hours. So some people gave 18 hours on that day. Since it was only one day and it was a kind of a trial setting, we were able to achieve large number of hours on the day 1 and day 2 also. What we found, because the common time when you get hypothermia, so we do get a lot of hypothermia. We may not think of it, but we definitely get mild to moderate hypothermia in at least 40 to 50% of all our postnatal ward babies. Okay, in some places it might be higher. So there was an 8 times reduction in hypothermia when we gave skin to skin care in the postnatal ward. So rooming in, the ideal thing should be when a baby gets delivered on the mother's skin and remains in skin to skin care. The Cochrane review says for WHO guidance is at least for 1 hour. There are studies that even if you give for 2 hours, it is even better. And then the baby, when she gets shifted, there's a break of 5 minutes because of transport of the mother in busy delivery rooms that might happen. But we can continue giving skin to skin care in that position for long duration. And if you give it good enough number of times, because the maximum hypothermia happens in the first 6 to 8 hours after birth. If you have kind of ensured that during that time baby remains in skin to skin care, you have prevented hypothermia significantly. So I think that would be my way of looking at it.
Thank you very much, sir. And once again, thank you all the participants for being part of this wonderful session. Thank you, Dr. Sanjeev, Dr. Sri Krishna, Dr. Shekar, Dr. Vani ma'am, all of you. And this session wouldn't go waste because we are getting a lot of feedback that they've got inspired and motivated to do kangaroo mother care as much as possible. And we all would pledge as a neonatologist and pediatrician that we will give our 100% and give our personal best to promote and to create awareness across us. So that itself will be, a great push for the kangaroo mother care. Thank you, all the doctors, all the neonatologists, pediatricians, and all the wonderful people who have joined, and all our nursing staff. We have shown a lot of interest. Thank you very much for joining. Thank you, sir. Thank you. Thank you. Thank you. Thank you all. Thank you. Thank you. Thank you.